Well, thank you very much. I certainly want to thank Pam Coons and the other organizers for inviting me. It's actually great to see you all here, and I apologize for being late, but I'm really glad to be here. So in terms of what's new for carcinoid syndrome, there's not a ton that's new, but, whoops. What I'm going to do is just review sort of a basic overview of carcinoid syndrome, talk a little bit about the management, and then we'll touch on a few specific topics that may be relevant for you towards the end of the talk. So just a reminder, and I'm sure that you are familiar with this by now, but just a reminder that carcinoids are typically classified by site of origin, foregut, midgut, or hindgut. And the reason why that's relevant in terms of carcinoid syndrome is that depending on the site of origin, you'll see differences in biology. So you can see that some tumors, particularly of the midgut, are really relatively indolent, where tumors that arise in other sites, such as the hindgut and the foregut, tend to be a little bit more aggressive. And then similarly, if you look at carcinoid syndrome, the likelihood of developing it, it's quite rare in hindgut tumors. It's fairly common in midgut tumors, which often are associated with traditional carcinoid symptoms with flushing and wheezing and flushing and palpitations. And then in the foregut, you can get traditional carcinoid syndrome, including wheezing, but you can also get some unusual syndromes like Cushing's, and we'll talk about this in a little bit, which is due to ACTH production. And there again, gastric carcinoids can produce a slightly different carcinoid syndrome. So the point being that it's certainly not all the same in individual patients, but it also varies by site of origin, both in terms of the likelihood of developing syndrome and also the features of syndrome. So it turns out if you take all patients with carcinoid, only a subgroup actually has carcinoid syndrome. And I think this is important, and it sometimes is confusing to patients and to some doctors that you can have, certainly can have carcinoid without syndrome, which are symptoms related to hormone production. Typically, the symptoms are related to serotonin overproduction, but it turns out that there are other neuropeptides that can be released into the circulation. And interestingly, the release of these peptides can be triggered by a variety of things, including exercise, stress, and certain foods. And so many of you out there who might be suffering from carcinoid syndrome are probably well aware of this, that there are certain triggers that will cause your symptoms to flare. The symptoms really are very pleiotropic, and I would say it's not identical in any way from patient to patient, but things like abdominal pain, flushing, diarrhea, palpitations, sometimes wheezing, and then there can be often some confusion about what flushing is. This is a dry flush. It's red, sometimes deep purple, and it's very different, for example, than sweats, where you might have a wet flush. Some of the other things that can happen associated with carcinoid syndrome due to the presence of the high serotonin and other peptide levels is that you can see right-sided heart disease, both of the pulmonic and tricuspid valve, and we'll talk about that in a little bit. You can certainly see mesenteric fibrosis, which is scarring in the abdominal cavity. Very rarely pellagra, which honestly we don't see much in the United States due to our fortified foods that we eat. But this is due to changes in tryptophan metabolism, due to the high levels of serotonin. And what you can see ultimately in some patients would be dementia, diarrhea, and a dermatitis. But again, this is very rare in our population, although certainly if you see a nutritionist, they'll often recommend a niacin supplement, which can help to prevent the development of pellagra. The classic syndrome is actually pretty rare. I mean, patients present often with some symptoms, one without the other, and it's pretty uncommon to see the perfect classic carcinoid patient. And again, it varies much from individual to individual. Serotonin is thought to be the key driver for carcinoid syndrome, but again, there are other peptides that can be made that we typically don't measure in the clinic, things like histamines, which are thought to be associated with the asthma-like features of carcinoid syndrome. Kinins, like bradykinin, are thought to be associated with things like bronchospasm, perhaps low blood pressure. And then tachykinins, things like substance P, even VIP, neurokinin A, may be associated with flushing as well. So a variety of different peptides, not all of them are routinely measured. The main one that we typically measured would be serotonin. or its derivative 5-HIA. And as I mentioned, the specific syndrome really depends on the site of origin, the hormone produced, and I think presumably individual patient factors that we may not have sorted out yet. In terms of 5-HIA, just to clarify what this is, what happens is tryptophan is converted through tryptophan hydroxylase to 5-HTP, which is then converted to serotonin. That's again thought to be the key driver of the symptoms. It's then metabolized to something called 5-HIA. That's actually what we pick up when we do the test for 5-HIA, either in the blood or the urine. So in terms of biochemical testing, just to remind everybody, chromogranin is a peptide that's often made by these neuroendocrine and secreted by neuroendocrine tumors, but having an elevated chromogranin is not synonymous with having carcinoid syndrome. That's really a different thing. Chromogranin is just elevated in many neuroendocrine tumors. I would just point out that it can be elevated for other reasons, such as renal dysfunction, being on a proton pump inhibitor, which people often use for stomach problems, gastritis, and ulcers. Pregnancy, atrophic gastritis, steroids, those are all reasons that people can have an elevated chromogranin. So this is one of the confounders and one of the things we always need to think about when we're checking serial chromogranin levels. But what we really typically do, the gold standard for carcinoid syndrome, is to measure urinary 5-HIA. This is thought to have less variability than doing the blood serotonin. I know some people do get their blood serotonins drawn, but just be aware of the fact that's quite a variable test, very contingent on what you've eaten. The urinary 5-HIA test is a bit of a pain. You have to watch what you eat, and I've listed the foods that need to be avoided in the 3 days leading up to the urinary collection, which is a 24-hour collection. So it's a bit difficult to do this test, but it remains the gold standard for assessing for serotonin overproduction. And again, we're looking for the metabolite in the urine. There is a new test that I'll just mention. I think many of you may be aware of this. This is a plasma 5-HIA test. It only requires an overnight fast, so it's considerably easier than doing the 24-hour urine collection. And I would just say that this is a new test. We're starting to learn how to use it in the community. It hasn't yet become the gold standard, at least in terms of clinical trials, where we're still doing the 24-hour urine 5-HIA, but I think we'll be hearing more about this test in the coming years. Now, there are a number of other hormones that can be checked, and I've listed them here, and this varies widely from practice to practice, from doctor to doctor, what you test. Truthfully, I haven't found any of these, the ones of these that I've tested, to be really reliably helpful, even when I've looked for it in somebody with wheezing that was unexplained. But these tests are available, and I list them just for completeness sake to know that they're out there. Now, in terms of the management for carcinoid syndrome, I would say it absolutely hinges on using somatostatin analogs. The availability of those drugs now, more than 20 years ago, has really changed our ability to manage this syndrome. But somatostatin is a bioactive neuropeptide which actually is present in all of us. It's normal. It has, physiologic role. Mediates its effects through 5 different somatostatin receptors that are expressed throughout the body. And you'll note that they're expressed in the central nervous system, the GI tract, the endocrine and exocrine glands. They are thought to actually do a variety of things in the body, including decreasing glandular and exocrine secretions, and they also appear to have an anti-proliferative effect. Now, this slide is a little bit complicated, but the point I want to make here is that there are these 5 different receptors, and they probably have overlapping but not necessarily identical functions. So this is important to keep in mind, because the traditional drug that we use, octreotide, mostly binds somatostatin receptors 2 and 5. So just keep that in mind, because one of the areas of interest moving forward is to identify analogs of somatostatin that maybe bind other receptors, and we'll be getting to that in just a second. Probably the effects are both receptor and tissue specific in terms of what happens when somatostatin or its analogs bind these receptors. So in terms of neuroendocrine tumors, one of the key features of neuroendocrine tumors is that they express somatostatin receptors. And of course, we take advantage of that in imaging when we do a test called an octrea scan, which is essentially a radio-labeled tracer on a somatostatin analog to find these receptors. And these are, again, upregulated in neuroendocrine tumors. But we think it turns out that if you use somatostatin analogs, which have now been developed that can be generated and given to patients as a medication, that use of these agents can actually reduce the production of these hormones like serotonin or the secretion of these hormones. And so again, the main one and the one that's approved in the United States is octreotide, which comes in a short-acting form, which is given sub-Q, usually about every 8 hours, or a long-acting form, which is given IM, usually once a month, although it varies from patient to patient. There is another agent, lanreotide, which is quite similar in structure that's approved for syndrome in Europe. But the two of them, you'll see here, when they've been tested in clinical trials, they do a pretty darn good job of controlling symptoms. Around 70%, 75% of patients will have an improvement in symptoms. And if you follow serotonin levels, a smaller fraction of patients will actually have a significant reduction in the hormone levels. But again, this has absolutely revolutionized our ability to take care of patients with carcinoid syndrome. Now, I'll just mention, because I have a feeling that George or one of the other speakers has already touched on this, that for many years we used somatostatin analogs like octreotide to take care of symptoms like diarrhea and flushing. More recently, there have been data both with octreotide and very recently with lanreotide that they actually have an anti-tumor effect. And neither drug actually is thought to be associated with major shrinkages. That would be extremely rare with these drugs. But both drugs in clinical trials have shown evidence for disease stability, so slowing tumor growth. So now in our clinics, we're using these drugs not just to control symptoms, but also for tumor control. So in terms of side effects, though, as with any drug, there are potential downsides. Remember that octreotide is just a man-made version of a naturally occurring hormone in all of us called somatostatin. But when you give it at the higher doses that we give it, there are some potential associated side effects. One is discomfort at the injection site. And this is certainly true for octreotide, where it's an IM injection, and patients will often report that some months are better than others. Some patients will even report feeling like they had a missed injection that was just not injected in the right spot, and they felt like they had control that was less optimal that month. It can alter glucose metabolism, so you can have high or low blood sugars in patients. This is most often a problem in people, for example, who already have underlying diabetes. So we usually work with the patient's primary care physician and make sure that the sugars are being monitored as you get started on octreotide. GI symptoms can be pretty minor and can improve over time, including loose stools and cramping, nausea, flatulence. But I will say that there are occasional patients who really have a tough time with octreotide and will have significant problems with cramping and diarrhea. Those patients are exceedingly rare, but it's the reason why some people will use a ramp-up period of a week or two with short-acting octreotide, which is given in this sub-Q form that patients self-administer, just to make sure they're tolerating it before they get switched over to the long-acting form. Gallstones can happen in patients. It's more often sludge, but you can actually have gallstones. And this is the basis for why we typically take the gallbladder out. If a patient is going to have surgery for any reason, then we will preemptively take the gallbladder out if we're thinking that they're actually going to be on somatostatin for any extended period of time. Long-term, there can be effects on thyroid function and vitamin B12 absorption, and so we typically assess those once a year in patients on octreotide. And as I mentioned, the glucose control can be altered on octreotide. So hemoglobin A1C is a way of integrating sugar control over several months and being able to see basically what the general control is. So if symptoms persist after someone's gotten started on octreotide, there are a couple of things to think about and discuss with your provider. As I said, one is this idea of a bum injection, meaning it just really wasn't put in the right location. And I think this actually does happen periodically. And it's something to be aware of. That doesn't necessarily mean the drug isn't working. It just means it might not have been administered in the exact proper way. The other possibility is over time, patients may just need a higher dose of octreotide. And there's a lot of debate in the field about whether this is true and whether we can really study this and document this. But the maximum approved dose for octreotide LAR is 30 milligrams a month. There certainly are patients who have been treated for higher levels, but again, this is out with higher doses, like 40 milligrams a month. Some patients have even been on doses higher than that, like 30 milligrams twice a month. That's outside of the approved indication, and it's frankly unknown. It hasn't been proven that those higher doses are helpful, although I think anecdotally we all know patients who appear to have benefited from a higher dose. The alternative to do if you're having trouble getting authorization for a higher dose is using rescue sub-Q octreotide, which is another option. There's also other very rarely used alternatives, such as using an octreotide drip. There's some evidence that checking octreotide levels may be helpful, and that levels fall over time as patients have been treated for quite a while or years on octreotide, that their levels may fall. But again, that isn't routinely used in practice, and I think a lot of us will just try a higher dose of octreotide, or we'll try rescue octreotide and see if that's helpful for a patient. Changing to a novel somatostatin analog, I think, is an area of study, and I'm going to touch on that in a second when I talk about a clinical trial. But as yet, the only approved drug in the United States for carcinoid syndrome is octreotide. So what's happening in the future? Well, we certainly are exploring other means of controlling hormone-mediated symptoms specifically. New delivery systems would be one way. Other agonists, as I mentioned, there are 5 different somatostatin receptors, and so there's a lot of interest in trying to figure out if there are other, if you're able to change the specificity, could you improve the ability to control symptoms? There are a variety of other analogs that are being developed, hybrid analogs with dopamine compounds, thinking that there might be other receptors that are driving some of these symptoms. Non-peptide analogs, and then serotonin synthesis inhibitors. And one of them we'll talk about in a second that's being developed as an inhibitor of tryptophan hydroxylase. And the idea there is to actually inhibit the production of serotonin altogether, or certainly to minimize it. So getting to some of the clinical trials data then that are out there, this study looking at essentially at lanreotide versus placebo in patients with carcinoid syndrome that are pretreated. The data are expected to be out at ASCO, as far as I know, coming up at the ASCO in 2014, which is an upcoming meeting. And then there are 2 other studies that I want to mention here. The pasriotide versus octreotide study we actually have some data for, and then this telotrestat study is just getting going, and I'll show you the schema for that in a second. So pasriotide is a somatostatin analog. This is a new analog that's been in development for the last few years. It binds 1, 2, 3, and 4. It doesn't bind somatostatin receptor 4. It has greater binding affinity for somatostatin receptors 1, 3, and 5, slightly decreased affinity for somatostatin receptor 2 than octreotide. And so the question is, does this have an enhanced therapeutic efficacy compared to octreotide? And there actually were data that were just presented this June from this study, which is a randomized study in which patients who had carcinoid syndrome that wasn't adequately controlled by traditional doses of somatostatin were randomized to receive pasriotide or octreotide at a higher dose of 40 milligrams every 28 days. And they were randomized in a 1-to-1 fashion, and the endpoint was control of flushing and/or diarrhea at 6 months. And what happened, you'll see the original study design was for about 230 patients, 220 patients or so. And this study was stopped early based on an interim analysis that suggested that this was not, the drug wasn't working the way they had hoped. So it was stopped for futility. There wasn't any difference in response rate for symptom control. But I will say that what was seen was some evidence that there was delayed progression with pasriotide. And this, again, was not the primary endpoint for the study. The study was looking at symptom control. It was a very small study as far as our clinical trials go, certainly phase 3 trials go. But it certainly adds some evidence to this growing body of evidence that somatostatin analogs do actually have some benefit in terms of disease control. And so this has fueled interest in studying pasriotide. further as a potential agent for tumor control. Now, I will say, however, that pasireotide in this study was associated with a higher incidence of hyperglycemia, which is a high blood sugar. So it does have a different toxicity profile than octreotide. It was otherwise fairly well tolerated, but as I said, the trial was stopped early because it didn't appear to meet its endpoint in terms of being efficacious in patients with refractory carcinoid syndrome. So now I want to turn to the another phase 3 study that's ongoing, and this is a study that uses a tryptophan hydroxylase inhibitor. So just reminding you again of the pathway of metabolism and synthesis of serotonin. This is proximal in the pathway, and the idea is if you can inhibit tryptophan hydroxylase, that hopefully you can inhibit serotonin altogether, and you can hopefully abrogate some of the symptoms. So there have been some very small phase 2 studies with this drug, telotrestat. There was a European study as well as another randomized phase 2. These are very, very small studies, but the point I want to make is both of these studies suggested a reduction in symptoms. You can see in the European study a 46% reduction in bowel movements from baseline. The urinary 5-HIA was reduced from baseline. In the second study, which was a total of 23 patients, 56% had a biochemical response, and about 28% had a clinical response in terms of bowel movements, so about a third of patients. So this has led to this study, which is ongoing right now, which I just thought would be relevant for the group to know about. And this is a study that randomizes patients to placebo or 2 doses of the telotrestat for 12 weeks, and at the end of the 12 weeks, everybody can go on the higher dose of the telotrestat. So I think it's a great study. It's important to know this is open for patients who have 4 to 12 bowel movements a day, and there's a run-in period during which you collect your, you keep a diary of your bowel movements. So it's really for a specific subgroup of patients who have this number of average bowel movements a day. There's a companion study that should be available soon that's for patients who don't meet the criteria to go on this study, who have symptoms as well, but just don't meet the bowel movement number for this study. So this is open. It is open at UCSF, and I think it's open at Stanford as well, right? And at other sites around the country. So just to wrap up refractory carcinoid syndrome, I've really been focusing on things that are related to symptom control, hormones, somatostatin analog, but there's also another important piece of this, which is that you can also look at controlling the tumor and doing a better job of controlling the tumor, because presumably if you control the tumor, stabilize the tumor, many patients also have improvement in their symptoms. So I've listed a few options here. There may be a chance perhaps in the tumor board to discuss this further, but there are some other options that are out there. One would be interferon, which it's been used traditionally, I would say, more in Europe than in the United States. We used it a long time ago when we didn't have all these clinical trials and other potential options, but it's still out there and is a consideration, particularly for people who have really refractory syndrome, because about a third of patients will have a biochemical response or reduction in their hormone levels. So it's something to at least keep in the back of your mind. Certainly liver-directed therapies are appealing. Many patients have liver-only or liver-dominant disease. So whether it's something like surgical debulking or embolization with or without the radiolabeled beads like SIRT or TheraSpheres, those are all things that are a possibility in somebody to help control their symptoms. Chemotherapy is really of unproven benefit. We use it on a case-by-case basis. There are some patients who have benefit, but the overall benefit appears to be fairly low in the patients with carcinoid, so it's not widely used or routinely used. Peptide receptor radiotherapy, I know you guys are aware of. It hasn't traditionally been widely available in the United States, but of course there's a trial open now, including at Stanford. And then novel agents that are out there largely in the context of clinical trials. And so we're hoping that in the coming years we'll have some good data that will support new drugs being approved for this indication. So I want to finish up just talking about a few other topics here in terms of just hot button points in terms of carcinoid syndrome. One is refractory diarrhea, and this is something definitely to think about. If you're suffering from refractory diarrhea, it's not necessarily from carcinoid syndrome. And the reason why, I mean, it could be a refractory tumor, and we've discussed all the ways you can manage that. But one of the things you want to keep in mind is that you don't have pancreatic exocrine insufficiency. So this is fat malabsorption. People will describe stools that are sort of oily, that leave a ring around the toilet. They might have a really acrid smell, a sort of rancid smell. This actually can be readily treated with pancreatic enzyme supplements. So that's really an easy fix usually for patients. And so if you are having diarrhea that's like that, that's something to think about. Niacin deficiency is really rare, but again, we often put patients on a niacin supplement long term, but again, unusual in this country. Sometimes short bowel syndrome, so people have had a lot of prior bowel surgery, that can lead to diarrhea. In terms of other kind of tricks that people can try, sometimes ondansetron may work. This is a anti-nausea medicine that can help. Cyproheptadine, I'm not sure how widely available that is, but that's sort of been of historical interest that may inhibit serotonin receptors. So there are a few things here to think about in the event that you are having diarrhea that's recalcitrant that may not simply respond to higher doses of octreotide. Carcinoid crisis, this is sort of acute surge of hormones causing very immediate, potentially very serious symptoms that can happen. This can be life-threatening. This is different than just your baseline flushing and diarrhea throughout the week or throughout the months. This can be triggered by a variety of things, including surgery or embolization or stress or a car accident. Anything like that could trigger carcinoid crisis. You could have high or low blood pressure, wheezing, flushing, shortness of breath. Octreotide is the mainstay of treatment, and this is why we recommend patients with carcinoid syndrome get a medical alert bracelet that alerts medical professionals to the presence of carcinoid syndrome, so they think about this. If you're ever being prepped for surgery or you're in the ER, are there any situations where it might be triggered? So prevention is the best treatment. If you are scheduled for surgery, make sure your anesthesiologist and your surgeon know that you have carcinoid syndrome. We usually do give people an octreotide drip perioperatively in this situation, where people will be on the drip at least for about overnight or 24 hours, and then it's weaned off as patients are recovering from the surgery and it looks like they're out of the woods. And then you can switch people over to sub-Q octreotide and then eventually back to whatever their baseline octreotide level dose is. And we do this, by the way, even in patients on LAR. If possible, physicians and other providers should avoid epinephrine. This is a drug that is essentially adrenaline, and this can trigger carcinoid syndrome or crisis. So we tell dentists, for example, to not use epinephrine in their anesthesia when they're injecting and trying to do dental procedures. And there are other procedures where sometimes epinephrine is used, and we try to avoid it if possible. There are other tricks of the trade that can be used perioperatively if people are having problems with carcinoid crisis. But again, prevention is absolutely the best thing to do. So you just want to make sure that anybody who's doing a knee surgery or a gallbladder removal or any operation, that they're aware of the fact that they could precipitate carcinoid crisis. And then I want to mention just carcinoid heart disease. This is what we call right heart failure. It's where people will usually present with swelling of their lower extremities. This is in the setting of carcinoid syndrome, and essentially what you do is you get scarring or fibrosis of the heart valves. It's usually a late manifestation of the disease. There's some data that the risk of carcinoid syndrome correlates with levels of serotonin, so people with very high levels of serotonin may be at the greatest risk for carcinoid. You can easily detect this by, you can certainly pick up signs of it on a physical exam, but an echocardiogram, an ultrasound of the heart is the way to diagnose it. And I just want to point out that if you just have local disease, your serotonin is typically cleared by the liver, so you don't see heart disease. But if, for example, you have metastases that have spread to liver that are making serotonin, then the liver doesn't clear those, because those are immediately dumped into the blood. They go into the heart, where they can fibrose the tricuspid and or the pulmonic valve. Then the serotonin goes to the lungs, where it's actually cleared. It's actually metabolized to 5-HIAA. And that's the reason why you don't see carcinoid heart disease involving the left side of the heart. It's only the right side of the heart. And this is illustrated here, pulmonic and tricuspid valves. So what do we do about carcinoid heart disease? Well, it really varies on the patient, the clinical situation. It is absolutely something that can improve dramatically with medical management. If somebody has heart failure, lower extremity swelling, they're really, really tired from their heart failure, this is something that working with a cardiologist and an internist, just with medications, you can make a dramatic improvement in how patients feel. I will say, though, the mainstay is a cardiology evaluation, because in an otherwise stable patient, and that's the key thing here, somebody who's stable, whose disease is otherwise well controlled, they may actually benefit from ultimately fixing the valves and doing a significant operation to replace the valves. But again, we don't do it on all patients. It's not the right maneuver on all patients, but in selected patients, fixing those valves can really make a huge difference in terms of quality of life. Cushing's syndrome, this is my last slide on carcinoid syndrome. I just wanted to say that this is very rare. Typically, if you see it, it would be associated with bronchial carcinoids. It's associated with ACTH production, which leads to excess cortisol levels, which are steroids. So patients will present with new onset high blood pressure, diabetes, easy bruising, weight gain. It's very, very, it's actually pretty easy to diagnose if somebody has classic Cushing's syndrome. Certainly treating the underlying disease is thought to be helpful. The role of a somatostatin trial is less understood, but certainly many of us would try it. And then there are some special things you can do to try to actually prevent the production of the steroid hormones, therein reducing the effects in patients. So again, very special subset of patients with carcinoid syndrome, but I think it's just worth knowing about. So finally, I'll just end by saying that there are really two indications for intervening with carcinoid syndrome. One is certainly for progressive tumor. If we have evidence for that, of course, we always try to intervene. But also control of hormone-mediated symptoms is very, very important. And they're linked, but both important indications for starting therapy. So with that, I will end. Thank you very much.